Thank you, madam, for the kind introduction. Here I'm going to discuss few really interesting cases that are we are seeing them in our day-to-day practice, and I am here to emphasize the importance of morphology. So day by day, we are continuously going towards the newer inventions, cytogenetic studies, molecular studies, but still morphology is the guide to when the bone marrow is needed, which follow panel to advise, and which molecular studies, genetic study to advise. So I'm here with a few really diagnostic cases where morphology has proven very significant in treatment and fastening the process. So the first case, 27-year-old male, he came with a history of gum bleeding since 10 days. There was no organomegaly. And as routine peripheral smear was done, his CBC count were hemoglobin was 8.1, total leukocyte count 37,000, and platelet were 13,000. Here we can see the peripheral smear in which this atypical cell is seen. In previous case shown by Dr. Aniket Mohite sir, there we have seen such similar case, but the morphology of cell was different. We saw there abundant azurophil granules and few rod-shaped intracytoplasmic bodies. So that was the case where the typical scenario of faggot cells, and we have diagnosed it as a promyelocytic leukemia. Here, this is the variant of promyelocytic leukemia in which we are seeing folded nucleus. There are very few granules which are not visible at all. So this is the microgranular variant of promyelocytic leukemia. Fish was positive for PML rara, but by the time fish results were out, we can start the treatment on the basis of this characteristic morphology. And we very well know that these promyelocytic cases can worsen fast if not intervene with the treatment at the right time. So coming to the second case. Case number 2. So here is a 2-year-old female, came with pallor, petechi, and hepatosplenomegaly. CBC counts where hemoglobin was 5.5, total leukocyte count 21,200, platelet were 9,000, and blast were 25%. So this is the low power view. In these, we can see these blast-like cells. On higher power, we can see these cytoplasmic extensions. So this is also very characteristic of one of the acute myeloid leukemia, that is AML M7, megakaryoblasttic leukemia, in which on the morphology itself, we have narrowed down our diagnosis and we can further go for the treatment. Although flow cytometry and cytochemistry all are important, but still morphology is very characteristic here and we can proceed with the treatment. Coming to the case 3, 65-year-old male, he came with the complaint of abdominal pain. On examination, there was moderate to gross splenomegaly. Hemoglobin was 7.1, total leukocyte count 76,000, and platelet were raised 550,000. So this is the peripheral blood smear picture. Here we can see the myeloid lineage. All the stages of myeloid lineage is seen, starting from the blast to myelocytes, metamyelocyte, band form, and neutrophils. Along with that, basophils and eosinophils are also there. Although the percent of basophil and eosinophil is less in routine smears, but in this case, they were seen prominently. So seeing this peripheral smear, we can already come to the, we can narrow down our differential diagnosis to chronic myeloid leukemia. In the peripheral smear of chronic myeloid leukemia, we can see all the stages of myeloid lineage, and this is very characteristic. And by the time our confirmatory test by flow cytometry, cytogenetics come, we can definitely start for our treatment. So coming to the case 4, he is a 70-year-old male, and he was already a diagnosed case of CLL. He came for further evaluation, opinion, and treatment. His hemoglobin was 9.9, total leukocyte count 34,000, platelet were 1 lakh, and lymphocyte were 79%. When his peripheral smear was seen, we can see all these lymphocytes over here. But when we went to the higher power, we can see these cells which are larger than the regular lymphocytes with this coarse chromatin, and there were prominent nucleoli. So they hint toward the pro-lymphocytes. So CLL has progressed to the pro-lymphocytic transformation here. So therefore, there is a need of continuous monitoring and evaluation of already diagnosed cases as well, to see whether there is further transformation or any change, so that we can very well start the treatment in a different line. So coming to the case 5, here was a 64-year-old male, abdominal pain with fullness. Hemoglobin was 11.9, total leukocyte count was 2,890, and platelet were 90,000. So with these history and this CBC count only, we can think of pancytopenia cases. And when the peripheral smear was seen, already, although the count was less, but still, when Buffy code preparation was done and the WBC, we can concentrate over there. We saw these atypical cells with hair-like projections. And with this morphology only, we can very well diagnose it as a hairy cell leukemia. Although the cytogenetic studies are useful and flow cytometry, all are needed for confirmatory diagnosis, but from morphology itself, we have come to the diagnosis of hairy cell leukemia here. And as Dr. Manoj has already said, ki renowned person from social service, Mr. Prakash Amte, is currently suffering through this entity, and he is very well getting treated. So this is the immunophenotypic configuration of this hairy cell leukemia, and it is BRAF. BRAF mutation is the hallmark for this entity. Coming to the case number 6, 17-year-old female came with yellowish discoloration of eye since 1 month, and LDH levels were very raised. Her CBC was like, hemoglobin was 5.2, total leukocyte count 8,400, platelet were also reduced, and MCV was 130 femtoliter. So 2 cell lineage were reduced. So bicytopenia was there, and mean corpuscular volume was raised. From this, we get the hint, and when we go for the peripheral smear, we found this hypersegmented neutrophils. So hypersegmented neutrophils are generally, neutrophils have 2 to 3 segments, but they are called hypersegmented when the segments are 5 or more than 5. For saying or labeling hypersegmented neutrophils seen, we need to have more than 5% of neutrophils which are having more than 5% of lobes. Then they are called as hypersegmented neutrophils. When, although bone marrow biopsy is not needed, we only can go for, we can diagnose on the peripheral smear only. But still, if we see on the bone marrow aspirate, we can see these megaloblast. Erythroid cell precursors are seen, whose maturation is arrested, and the case was get treated for megaloblastic anemia. Coming to the case number 7, here was an adult male, 90 days post-transplant. Bone marrow transplant was done for aplastic anemia, and after 90 days, he developed sudden drops in peripheral count. On immunosuppressants, and he was on immunosuppressant for prophylaxis of graft versus host disease. His hemoglobin was 7.3. Total leukocyte count was also very low, 2,900, and platelet were also reduced. So he was going through pancytopenia. When the peripheral blood smear was done, we found these cells with intranuclear inclusions. The consultants all were worried how the counts are dropping. But when we went through the peripheral smear, we found these cells with intranuclear inclusions, and we then narrowed down to this must be some fungal infection leading to the pancytopenia, and the culture studies were advised. So these are the yeast-like organism, and culture concluded it to be Candida parasilosis, and the treatment was then directed towards the target. Case number 8. Here was a 22-year-old male. He came with pallor and jaundice since 1 year, and there was a past history for surgery for multiple gallstones. Apart from this history, there was not any major concern. So when he presented, the CBC showed hemoglobin to be 9.7. Mean corpuscular volume was low, 70 only, and MCHC was raised, that is 37 gram per DL. When the peripheral smear was seen, it showed these round cells with reduced central pallor. The polychromasia was seen, and reticulocytes were increased. So evaluating from the history that he was having history for treated multiple gallstones and jaundice, and on looking at the peripheral smear, we found these cells with low MCV and reduced central pallor. So spirocytes were there, and the condition we diagnosed it as hereditary spirocytosis. In the hereditary spirocytosis, osmotic fragility is increased because of the shape of the RBC. It is elasticity is reduced because of defect in the spectrin and ankyrin gene over the cell membrane, and therefore they get very fragile. And that's why the osmotic fragility test is one of the diagnostic for this condition. In this, osmotic fragility of the red blood cell is increased. Coming to the case number 9, here 70-year-old male, he presented with progressive weakness and breathlessness. Peripheral blood showed pancytopenia, and this peripheral blood smear image, here we have 2-3 clues over these. We can see the stack of coin-like appearance of RBCs. In our field, we call this as Rolex formation. There is slightly bluish background over here, and then this is some atypical notorious cells which is not commonly seen in the peripheral smear. So here in this cell, the nucleus is eccentric, and we can see here is perinuclear Hoff. So it is a plasma cell with this, although it is very rare to be found in peripheral blood smear, but in this case it was there, and this Rolex formation with slightly bluish background, which is very characteristic of the condition, that is multiple myeloma. So further, as a diagnostic line, when bone marrow was done, we can see these plasma cells in the bone marrow as well. See these cells in which nucleus is eccentrically pushed, this perinuclear Hoff, and basophilic cytoplasm. So on the morphology itself, we have arrived at the diagnosis of multiple myeloma. coming to the next case, which is case number 10, and it is actually already has been discussed by two of our speakers, how the machine count is like misleading. So here was a 14-year-old male, 14-year-old female came with a complaint of abdominal pain. The physical examination was unremarkable. She had no bleeding symptom, but the main concern was low platelet count. So the two differential diagnoses that the clinicians were considering was it may be ITP or marrow suppression by viral illness. But when the peripheral smear was seen, it shows these platelet clumps that was missed by our electronic cell counters. So after going through the peripheral smear, the clinician was advised to repeat the sample with citrate bulb or heparin bulb. And when it was done, the repeat testing in the new sample collected in the citrate tube showed the normal platelet count. So this was the case of EDTA dependent pseudothrombocytopenia. So although the platelet count in machine is low, the platelets have been clumped over here, which was giving the low platelet count. So in this EDTA-induced platelet pseudothrombocytopenia, this is a condition where EDTA directs against the glycoprotein 2B3A receptor of platelet, leading to the conformational change, which causes platelet clumping in vitro. So it is a general phenomenon, and it is seen in up to 0.1 to 2% of hospitalized patients due to EDTA-induced conformational change in glycoprotein 2B3A epitopes present on platelet surface, and the use of alternative anticoagulant such as citrate or heparin may be helpful. And this was the case of pseudothrombocytopenia. And one more condition which is misleading for low platelet count, and that is giant platelets. In this, in regular cell counters where impedance method is there, which go by the size of the cells, these giant platelets are not counted in platelet, and therefore the platelet count that we get is low. But when going through the peripheral smear and when we found this giant platelet, we can be okay for the normal platelet count, when one platelet is considered as 15 to 20,000 when seen on this under microscope. So these two cases were of pseudothrombocytopenia, where we went for the peripheral smear, we got the correct diagnosis. One was platelet clumping, and this was the giant platelet case. Now the last case here, a 4-year-old boy came with a problem of gastroenteritis, weakness, and oliguria. Physical examination revealed pallor, edema, and petechiae. So when we did the peripheral smear, we found these cells. These are the fragmented RBCs. So these are nothing but the schistocyte. We call them schistocytes when these are the fragmented RBCs with 2 to 3 sharp spicules are there, or there may be helmet shape, or they may be triangular shape. So when correlating the history and this morphological picture, we can definitely come to the diagnosis like this 4-year-old boy with the history of this gastroenteritis, urinary problem, and low platelet, bleeding symptoms, petechiae purpura, along with this schistocyte seen on peripheral smear. This much, these two things were ideally enough for coming to the diagnosis. Although other tests are needed, like this LDH retic, in which we found in these cases LDH is increased, retic is increased, but only the history and the peripheral smear examination was very helpful for coming to the diagnosis of hemolytic uremic syndrome in this case, which after adding all other investigation, it was confirmed. And therefore, because of low platelet, rather than giving platelets for such patients, we have to treat them in a supportive way, going by hydration therapy or dialysis when needed. So all these were the cases which we come in our day-to-day practice, and where morphology is really significant. So I would like to emphasize, like, whatever molecular genetic test and inventions we are going on, but old is gold and morphology is never out of style. Thank you.
कॉंग्रॅच्युलेशन डॉक्टर श्वेता. आता मला कळतंय की सक्सेसफुल हिमॅटॉलॉजिस्टच्या मागे पॅथॉलॉजिस्ट बेटर हाफ श्वेता तोष्णीवाल आहे. आणि आम्हालाही माहिती आहे फिजिशियन्सला की पॅथॉलॉजिस्टचं किती महत्व असतं प्रत्येक डायग्नोसिसमध्ये. त्यांच्याशिवाय आमचं चालूच शकत नाही. आणि तू इतक्या सुंदर स्लाइड दाखवल्या, आम्ही नुसते रिपोर्ट वाचत असतो. आज खूप दिवसानंतर इतक्या छान पेरिफेरल स्मिअरच्या स्लाइड्स आणि त्याचा इम्पॉर्टन्स ऐकायला मिळाला. खूप खूप अभिनंदन.
Thank you so much, madam.
Thank you, ma'am, for the beautiful presentation, coming up with interesting clinical presentations and its hematological correlates. I think it's a good lesson for all the budding pathologists, but budding hematologists in the making, so as not to ignore the subtle variations in the automated on the reports that are generated by the automated instruments, modern instruments. We have to rely on the basic peripheral smear examinations, and a lot of learning is to be inculcated through these routine examinations. Thank you very much.
Thank you.
एक सांगू इच्छिते की सगळे टेक्निशियन्स लॅब रन करतात, त्यांचे सीबीसी रिपोर्ट येत असतात. मी त्यांना प्रत्येक वेळी सांगते की मायक्रोस्कोपी लागते मला, एमडी पॅथॉलॉजी माणूस लागतो, पॅथॉलॉजिस्ट लागतो, मला हा रिपोर्ट चालत नाही. आणि मायक्रोस्कोपी फक्त त्यांनाच समजते. आणि त्याच्याबद्दल तुम्ही सगळ्यांनी ऍक्शन घेतली पाहिजे. सगळ्यांच्या टेक्निशियन्सच्या पॅथॉलॉजी लॅब बंद झाल्या पाहिजेत. IMA ची रिप्रेझेंटेटिव्ह म्हणून मी हे पण इथे सांगते.